Thank you, everybody. I think we're more or less ready to start. I'm just waiting for my colleague from WHO to join us. Rosamond, I see she's connecting now, so that's wonderful news. Let me, I think we're a full house now. So I'd like to just welcome everybody who's joined this webinar on COVID-19 in schools. It's a webinar that we at WHO are co-hosting with UNICEF. On the line as panelists today, I have with me Robert Jenkins, who's the Chief of Education at UNICEF. I have also Lisa Bender from the Education in Emergencies Department of UNICEF. I have Jerome Pfaffman, who is the Senior Advisor for Public Health Emergencies. Also with me, I have my colleague Rosamond Lewis, who is the lead of the Public Health Sciences Group in the Managing Infodemics group here at WHO. Rosamond's waving. And I also am very lucky to have with me Jacco Wellinger, who is from the Unit for Infectious Disease Modeling at the National Institute for Public Health and the Environment from the Netherlands, and Vittoria Kolitza, who is the Research Director from the Pierre-Louis Institute of Epidemiology and Public Health, Inserm-Sorbonne University of France. So welcome to everybody. And I hope this is going to be a very fruitful discussion. We have received some questions over email that if there is time, we will try to answer as a panel group at the end of the presentations. This webinar will be recorded, so the recording will be available later for those who have missed it or who are interested in sharing it with others. So I'd like to first of all hand over to Robert and Lisa to make some opening remarks and to have the first presentation. Robert, over to you.
Thank you very much. Good morning, good afternoon, good evening, colleagues. I'm very happy to have this opportunity. I think best for me to be very brief, recognizing the other panel members and also the participants. I really look forward to discussing what I'm about to present. What I am going to present is what we're basically calling a framework for opening up schools. We'll just move to the next slide, please. First of all, there was a guidance issued a month ago on preventing and controlling COVID-19 in schools. This was co-released by the World Health Organization, the IFRC, and ourselves. And this provided what's on the slide. It provided an overview of kind of what's needed to be known at country level on keeping schools safe, and then more importantly, also some key practical steps and actions that can be taken in order to ensure schools remain safe. It was based on evidence of previous epidemics, including the Ebola crisis in West Africa, but also informed by the steps that were taken in response to the Zika virus. And and you're going to hear me say this a couple times during this presentation, this guidance and the framework that I'm also going to talk about emphasize the importance of contextualizing the analysis and contextualizing the actions. And I'm sure the other panelists, and we're all going to recognize that at the global level, there's only so far the conversation can go, recognizing how important it is to contextualize these decisions and contextualize the actions. Next slide, please. From the guidance came supplementary content, and that really is tools and very practical checklists and summaries of evidence that enabled countries to take concrete actions to ensure schools were safe. This was at the time when schools were making the decision on whether or not to close and what actions could be taken at community level and at school level during that period, and it was proven to be a very useful tool. Let me now move to the framework for reopening schools. We recognize that from an education point of view, the response to the pandemic went from across the world, unparalleled school closures, to remote learning, which is now taking place in the vast majority of countries, now to the discussion on reopening schools. And most countries, if not all countries, are somewhere between remote learning and reopening or have reopened. Now, the framework for reopening schools was issued yesterday, and it's a framework that was developed by UNICEF, UNESCO, the World Bank, and the World Food Program. And it also emphasizes the importance of contextualizing the decision to reopen schools, and also provides guidance and very clear tools and methods on how to reopen schools. And I'm going to move into that a little bit into greater detail now. The idea, the simple idea is, the framework recognizes, and I'm sure all will agree, that prolonged school closures or prolonged absence from learning, depending on the access to remote learning, has greater impact on children, greater negative impact and greater risks on children. And again, the importance of contextualization, but in this case, contextualization on each and every child. What is the status of the child? How marginal, how vulnerable is the child? And that includes their current access to remote learning and the benefits of schooling. I'll come back to that a little bit more. But now, from an education point of view, like myself, we of course focus on the last bullet point, the importance of the learning losses and how important it is to maintain children on learning pathways during school closures. Now, and that's the remote learning part. However, we need to recognize, and this was a lesson from the Ebola crisis, when we all remember there was also prolonged school closures. In some countries, 9 months, the schools were closed. The impact on children is beyond learning. And that's a recognition that schools provide a whole range of services, in both health and well-being and nutrition support through school feeding, etc., but also a protective envelope and shield, if you'd like, for children. And we saw very real increased protection risks for children during prolonged school closures in response to Ebola. And we see some data now among the protection concerns of children as a result of school closures, and also very real impact on their mental health and psychosocial well-being. So it's just always important to recognize the decision around school closing and school reopening and the importance of remote learning. We have also a broad range of support that children are now requiring as a result of school closures and need to be addressed. Ultimately, the framework calls for the need to take action from this recognition. Next slide, please. Now, when deciding to open schools, of course, there's many different ways of looking at this, but the framework presents two simple dimensions. This first dimension, let's call it, if you'd like, the horizontal, along a horizontal axis, is looking at the benefits of reopening schools, and that also needs to be contextualized. And the benefit of opening schools from a learning point of view is classroom instruction. When you're assessing benefit, it's assessing the benefits of classroom instruction vis-a-vis remote learning. Now that depends on a few things. One, it depends on the availability currently of remote learning. And obviously that's very context specific. We have a full range of countries and communities, a full range of access to remote learning and the quality of that remote learning. And just to maybe take a sentence on remote learning, of course, that can be IT enabled, meaning on computers. It can also be on apps on phones. It can be delivering of learning materials to homes. It can be television, radio, and we've seen 60, 70% of countries in Africa, for example, using the radio. So it's a whole range. So it's an analysis of reopening schools vis-a-vis that availability of remote learning in country and context wise. It also very much relates to each and every child again. The benefits of classroom instruction vis-a-vis remote learning are different for children who are younger compared to children who are older. It is also very different for children who are approaching high-stakes exams. Overall, from an education point of view, there's a recognition that remote learning is more challenging for younger children. So therefore, the benefits of reopening schools is higher for younger children than for older children, recognizing, again, of course, the comparison to availability of remote learning. So within each context, the framework calls for an analysis of the benefits of reopening schools vis-a-vis remote learning. The second dimension, a very, very important dimension, is the risks that related to reopening schools. This is also very context specific. The framework is very clear that the driving force of the decision has to be the safety and well-being and health and well-being of children. So this dimension is obviously incredibly important. And the public health officials and outside of education experts in this field need to inform the decision on the risks related to reopening schools. Now, the risks can be put into, the framework puts them into two broad categories. One is associated with the capacity of the school system to mitigate risks. And again, that's very context specific. Capacity of the school systems relating to the capacity to enable social distancing at school, the capacity of the school to provide water and sanitation and hygiene, the promotion of certain behaviors, etc., are obviously context specific. There are also very real community risk factors, transmission rates, the link between the school and the community, public transport systems. So again, all of these context-specific analysis has to be factored in. And then to the next slide, please. The framework calls for putting these two dimensions together. So looking at the benefits, looking at the risks and all their dimensions, the benefits and all their dimensions, disaggregated by context, by each child's age and learning. Similarly, the risks contextualized, then the decision driven by what's in the best interest of the child, driven by what the paramount importance of safety and well-being of children, but also recognizing the risks of prolonged school closures and absence of learning, and the protective and social, emotional, and health risks associated with school closures. The decision is taken at country level to how and when to reopen schools. When that decision is taken, we move to the next slide. The framework lays out some dimensions that we would engage with at country level on the planning of the reopening process. And we come back to the original guidance I mentioned that was issued 5-6 weeks ago on how to ensure schools remain safe, very practical interventions that can enable safe school operations. Then there's guidance around learning. Obviously, as the prolonged nature of school closures, very proactive measures need to be taken to enable catch-up programs, accelerated learning, bridging back children into the school, and enabling effective pedagogy for a now diverse range of children. The framework is very clear and encouraging proactiveness on reaching the most marginalized children. And that is also a lesson that has been learned from earlier school closures to earlier epidemics, and that the most marginalized in many cases, especially at older age groups, for example, girls in West Africa, as in the time of school closures, in response to Ebola, the high percentage of older girls that never came back to school. So the framework is very clear that the importance of proactively focusing on and enabling bridging of the most marginalized back into the school system. It encourages a broader approach to opening up the school from a well-being and protection perspective, in addition to learning, then cutting across those very four keep sort of buckets of practical issues that need to be analyzed at country level. There are some policy decisions that must be taken and financing decisions. So those are the 4+2 dimensions while planning and managing the reopening process. The framework then encourages a work plan to be developed that is put into 3 simple stages. Encourages a certain actions to be thought through on planning for the reopening, then during the reopening process itself, and then after schools have been reopened, how to manage the medium to long term, including the importance of monitoring learning, monitoring well-being, monitoring access, etc. Let me just shift to the last slide and land on the overall recommendations. The framework focuses on infection prevention and control. It's very strong in the actions that can be taken. It recognizes secondary impacts and the importance of, in addition to moving beyond the impact on learning. And also we look at the importance of seizing this opportunity of reopening schools to reopen stronger schools and better schools, if you'd like. And that can include innovations that have been introduced as part of the remote learning process, including many IT-enabled initiatives that can now bridge children and continue in schools post the reopening process, but also, again, looking at additional services that schools can provide. From lessons from previous school closures, we recognize that as children walk into the front door of schools, when schools are reopened, they will be more vulnerable from a learning, but also health and well-being perspective. And the school then, as it reopens, we're encouraging it reopening with a broad range of services to meet their broad range of needs. Last slide, please. Let me just take this opportunity to thank to all of you for this opportunity to present, but also the collaboration between the agencies that issued this framework, and I look forward to the discussion. Thank you.
Thank you so much, Robert. I'd like to just recognize that it's really an early hour for you there in New York, and thank you for getting up at this uncomfortable hour to share with us. Lisa, I wondered if you would like to make some comments now, or perhaps at the end before we move to Rosamond. Perhaps we can come back to you at the end then. I'd like to now hand over to Rosamond Lewis, who has been leading some of the work at WHO in terms of the public health and social measures around COVID-19. Over to you, Rosamond.
Thank you, Sarah, and thank you, Robert. It's a pleasure to join you here on this chat today. Yes, we have documents coming out of WHO. As you know, that's what we do a lot of the times, other things as well, but guidance documents on public health and social measures, which includes various things like contact tracing and testing, but also includes very much the guidance on implementation of social and physical distancing, cleaning, environmental cleaning, and those various measures. And there's going to be a suite of documents on different sectors of society, so schools, workplaces, and other things. As societies wish to reopen, as Robert has very clearly outlined, closing schools and reopening schools is something that needs to be done thoughtfully and carefully as much as possible, because it involves not only the students, but also the parents and or caregivers, the teachers and other staff, and the community at large. And what is the context of that local community? We can think of something in Sweden, or we can think of something in Uganda or Senegal. It might be very different. So what do we consider when we're suggesting closing, or in many countries now already reopening schools? What we're suggesting is a risk-based approach. I think Robert has already mentioned that there are benefits and risks to both sets of actions, and there are ways to do things that can be a little bit safer. But first, let me just talk about what we know about COVID-19 and children. So we're talking about schools, we're talking actually about educational institutions. Whereas UNICEF does focus on younger children and perhaps adolescents, we're also talking about preschool, primary school, secondary school, and universities. And we need to think about this whole range of educational institutions, including boarding schools, for example, where measures that are put in place may vary considerably based on age, as Robert has mentioned, or other factors. But let's just go back to children for a moment. So a recent review of what is known about COVID-19 infection in children suggests that children are less often infected than adults, and I think we know this already, and that infection without symptoms may also be more common. We also know already that severe disease is seen much less frequently in children, but there have been quite a number of case reports now of children who have suffered serious illness, and a few have died in a number of countries. So it's not a complete silver lining as it is, but already we know that most children are much less infected and much less severely ill. So it is a consideration on the risks and benefits, as UNICEF has pointed out. The benefit of closing schools for the purpose of COVID-19 needs to be balanced with the risk for the same children, and that's really important. We have less information on the role of children in transmission. It remains quite unclear, and we do still have contradictory evidence. And it's difficult to provide clear recommendations in that situation where we still actually don't know enough about transmission in children. Part of it is a testing phenomenon, so children are not so ill, so they don't get tested as much. And part of it is simply that some anecdotal evidence suggests already that children are getting infected by the adults in their household, for example, or the adults at school less often than actually from other children. It's actually very different from influenza. And this is important because a lot of the school closing measures were kind of studied and worked on and put in place in the context of influenza, which of course seasonally happens every year, but also the occasional pandemic. And for COVID-19, what we're learning is that for children, the role of children in transmission is quite different, and we still have a lot to learn. People are concerned about super spreading events, and many, as you're aware, have happened related to cruises or religious events. There's very few that have actually occurred related to schools, however. 2 in the university setting were related to events outside the classroom, a trip or a social activity. And the only one that so far has been clearly reported from a primary school has been related to an outbreak in children related to a teacher who brought the infection into the school. So basically the message from this is that although we don't know a lot right now, suggestions are that, that the school classroom may not be the highest risk location for children. And it encourages us to think that we can safely reopen schools for all the reasons that Robert has outlined, as long as we put in place those protective measures because of that uncertainty that we still don't have all the answers. We actually don't know right now also about the immunity in children and whether they develop an antibody response, because there's a suggestion that antibody response is stronger and faster in people who have severe illness. And since most children don't have severe illness, we also don't know whether their immunity is conferred by an asymptomatic infection or a mild illness, for example. So there's still a lot to learn around the public health and infectious disease aspects, and I'm sure we're going to hear more from the next speaker on some of the assumptions that are needed to be made for modeling. So what are some of the things we think about in addition to what we've already heard? We definitely want to think about the local epidemiology of COVID-19, both at the national level, but also very much at the community level. I think we've all learned that this outbreak can move from community to community in very different ways and be at very different stages within one country. So I think even at the community level, one needs to ask, is the outbreak declining or over in your area or community? Are new cases still appearing? Are health facilities coping? These are the questions we've been dealing with so far, but it's also relevant for a school because, as I said at the beginning, it's not only the children in the school, it's who they're living with at home and who they're in contact with in the community. Are they in contact with their parents, of course, their caregivers, or if it's a boarding school, teachers, older teachers, and also, of course, their own grandparents. So this is really important consideration. It's not just that it's safe for children, but what's the degree of risk or benefit for the community as a whole and the children's families. And importantly as well, are public health officials able to identify new cases? This is a challenge in many countries still to identify sufficiently new cases at the local level, especially for people who have fewer symptoms. But as testing gets scaled up in countries around the world, we hope that that's the intention for most countries, if not all countries, to really dramatically, especially as we lift measures for schools, workplaces, public transport, it's going to become even more important to test suspected cases, not everybody, but definitely suspected cases, and trace their contacts for isolation of cases and contact quarantine, because this is what is going to help us keep the lid on reemergence of infections in these communities. So the school needs to be prepared to provide public health officials with information. If there's a case in their school, they need to be able to say who was all in contact with that child or that adult, and that's really important for contact tracing. And so that's the EPI, and that's already quite a lot of information. But in the school setting, we're also looking at, in addition to what has been described, the behavioral aspects related to the school community. So are students able to comply with the behaviors requested when they come back to school? So I won't go into all the detail of physical distancing in the classroom and so on, but you've seen a lot of countries are starting to lift measures, and they're in fact saying, well, we will limit classroom size to 15 students, or we will make the return to school voluntary versus mandatory. Countries are doing it differently. And what needs to take place in that environment. Hand washing has been mentioned. Do the schools have access to sanitizing gel? And are the students able to comply with what's requested of them? So hand washing on arrival, hand washing before meals, after meals, when moving between classrooms, are there enough supplies? But also, can supervision be maintained? So if children are sent out into the playground, what are the mechanisms going to be to reduce, not that they shouldn't play, but perhaps to reduce mixing between the very youngest and the oldest ones in the school, for example. So there's many strategies that can be thought about to achieve these things, such as more rolling of lunch breaks or of recess breaks, so that there's overall fewer people in the playground or in the hallways at any one time. Suggestions that in junior high or high school, rather than having the classes move, it's the teachers that move, or one-way passageways along the hallways. And so these are all behavioral adjustments that are going to be requested of children, regardless of their age. They should be adapted to the age, but they will be quite new for them, and therefore they need to be cut some slack, but also trained and supported in those things. And all these things also going to be commensurate with local cultural norms, for example. And as a student community, parents and teachers willing to support all of this, or do they want to keep their children at home? Or it has to be a community dialogue. It's better if it's a community dialogue. Let's just put it that way. As to the school policy, practice, and infrastructure, there are many things that that can be put in place. As we've mentioned, the hand hygiene, the physical distancing, limiting of crowding, not only in the classroom but in social circumstances around the classroom. And this is particularly important for university level, because they're not kids anymore, and they have to be, a certain level of personal responsibility needs to be taken on, but also it can be enabled and facilitated by some policies or measures that for example, post-secondary authorities, institutional authorities put in place. More important for lower income settings, does the school even have enough space? If the authorities would like classrooms to be limited now, in a given country to 15 pupils, that's going to be very difficult in some countries where classroom sizes can be upwards of 30, 40, or 50 kids on benches in one class. So again, very different context. Can the classroom be taken outside? Can it be taken into the garden? Can it be taken into the schoolyard, under a tree? And that applies in all contexts, actually. If all children go back to school, it may be the rotating class, half the class is in, half the class is out, and so on. So a whole range of strategies could be considered. I won't go into all the details of for example, cleaning and things like that. That information is very much available online already, but if you need additional information, we can provide links and so on. I just like to think a little bit also outside the box of COVID for the moment, and the very relevant mental health and psychosocial elements that you've already discussed, but also that we're trying hard to recommend that essential services be maintained. And by that, I'm thinking essential health services, access to care. And we know that many of the health workers will be otherwise occupied, but hopefully not in the waning phase of the outbreaks. They'll be a little bit freer. But this return to school idea is really an opportunity to revisit immunization status. Are the children coming in at young ages protected against measles and all the usual routine infant immunizations? Are all the kids protected against outbreak-prone diseases? Again, measles comes to mind. We know that in Ebola, for the Ebola outbreak in DRC for the last year and a half, that twice as many children have died of measles as adults have died of Ebola. We're talking about 3,000 deaths for Ebola and 6,000 measles deaths in children. So it's really, really important consideration that we are facing a critical situation, but we don't want to create new critical situations. So we have measures in place, vaccines and other things that should be part of the checklist for return to school, because it would be a shame to miss that opportunity to do so. Some of the ideas around physical distancing in school include desk spacing, keeping the desks 1 to 2 meters apart in the classroom. We've talked about limiting mixing of classes, taking classes outside. And then the safety and security aspects, I think you've heard quite a bit about from Robert already. But just to add that, you know, there may be children who really need to be in school because that's the only place they get a square meal. Or they need to not be confined to home for too long because there may be some suspicion of maltreatment at home, and child protection services need to be involved. So it's complex, but it's interesting, and I think we all can think about innovative ways. WHO does not have the answer to each and every individual local situation. I think the real message I'm trying to get across is that there are so many things that could be done, but they rely on innovation at the community level and engagement between school authorities, parents, and local community services. Even if the policies are made at national level, how to implement them becomes a range of local solutions. Thanks, Sarah.
Thanks so much, Rosamond. Lots of things to take into consideration, like you said, when planning for the reopening of schools. And I think this is where we're really very happy to have both Jaco and Victoria on the line, who have been involved in some of the modelling work in their respective countries that is ongoing in order to inform policy decisions around the reopening of schools. So Jaco, I hope I'm saying your name correctly.
Yeah, that's fine.
Over to you. I have your slides here, so I can present them, and then if you just say next slide, then we should be ready.
Yes, so this is just a story from what we have done in the Netherlands, and it's not just me, but also my colleagues who are listed here as co-authors, including people at the London School. Next slide, please. Next slide. So the background of the epidemic in the Netherlands, which I think it's not a special story, but on the graph in the left upper hand corner, you see the epidemic curve. That's the hospitalized patients by hospitalization date in blue. So you see that we've had most hospitalizations around the end of March, and now it's in a declining phase. From this epidemic curve, we can calculate the number of hospitalizations by symptom onset date. That's the red curve you see. And you can see that most people had symptom onset around 16th of March. And also that is declining now. So that's the reason why in the Netherlands we are considering school reopening. Like we can translate this red epidemic curve into what we call the reproduction number, the number of secondary infections per infection. That's the graph you can see in the left lower hand corner. And from this, we can see that in the beginning, before control measures were in place, on average, there were about 2 secondary infections per infection in the Netherlands. When measures were put into place, like the number declined, and now it's just below 1. Next slide, please. And I use the same curve to pinpoint the kind of measures that were taken in the Netherlands. Again, that's also not such a special story for a country in Western Europe. Like, we found the first case at the end of February and started case finding and contact tracing. There were some regional differences. So at the beginning of March, there was an advice for the region in the south for people to stay at home when they were symptomatic. And from 9th of March on, there were measures for the whole country. And on the 12th of March, there was advice to work from home. And on 16th of March, the schools were closed and daycares were closed. And also, and we believe that's a very major measure that contributed to stopping the spreading, is also the closing of all pubs, restaurants, sport clubs, and so on. Next slide, please. So what we have done in the Netherlands to see if we could reopen schools and start like changing our contact measures, our measures a little bit, is to look at the contact patterns in the Netherlands. We observed these patterns in cross-sectional surveys that were done. We had one done in 2017 in a random sample of the general population, and we repeated that in beginning of April 2020, when the measures were in place. And in this survey, participants reported on the number of different persons they contacted during a day. They recorded, of course, their own age, the age of the person they contacted, and the setting of this contact, including home, work, and school. And that's what we use when we think about school closure. And so next slide, please. So here is the pattern you see. This is what we observed in our survey. On the left-hand side, you see a typical contact pattern by age in 2017, before the epidemic. You see on the horizontal axis the participants' age, ranging from 0 up to 90. And on the vertical axis is the contact's age. And like when there are a lot of contacts between age groups, they get a yellow color, and when there are very few, they get a blue color. So you see here confirmation from what everybody already knew, that most people contact others of the same age. And there are quite a few contacts of, say, very young people with people 30 years older and vice versa. So children contact their parents. And we repeated this survey in 2020 after control measures were made. And you see that on the right-hand side, again, with participants' age on the horizontal axis and the contact's age on the vertical axis. And you see that overall, there's a drastic reduction in the number of contacts. So depending on how you define the average, it's between 63 and 74% reduction. You still see very vaguely that most people still contact others of the same age. But this is what we see. So there's been a drastic reduction in number of contacts throughout the entire population. And next slide, please. When we split this up by the setting of the contact, we can see a number of contacts that are done at home on the left top hand corner. And then in the middle on top, there's contact pattern at work. And then on the right top hand corner, there is the contacts at school. And what we see is that school accounts for about 18% of all the contacts that are made in the general population. And then there are also contacts we observed in transport and during leisure and in other places. And so this gives us a little bit of an idea of how many contacts are made at school and who contacts whom at school. Of course, there's no surprise that most kids contact others of the same age at schools, but we have some idea of how many contacts there are relative to the total number of contacts. And next slide, please. This allows us to do a quick back of the envelope calculation. Like we have in the left column, the different settings of contacts. On the column next to that, we have the contribution to the total number of contacts. So we see that school contacts account for about 80% of all the contacts in the population. Then we have the assumed change in contacts by taking the control measures. So we assume that that's by closing schools, about 80% of all the contacts between kids of similar age was decreased. And at the same time, there are more contacts within the household setting because children stay at home and there they make different contacts, usually with their parents or caregivers. And next slide, please. This allows us to get a little bit of an order of magnitude for what happens if we would now reopen schools. Like we assume, basically using the graph that I showed on one of the first slides, that the reproduction number is about 2, so 2 secondary cases per primary case before we took our measures. After we took our measures, it's about 0.8 in the Netherlands. And if you now would assume, just suppose that if children are at most as susceptible and at most as infective as older age groups, this is a bit in line with what we've heard in the previous presentation, then we can say that by opening daycare and schools and primary schools, we have at most about 0.2 additional secondary infections per primary infection. So that's like what we think the worst that can happen. And when we open schools also for, if we also open the secondary schools, we have at most another like 0.2 additional secondary infections. It's a little bit higher because here we also account for more use of transport to go to schools because the schools tend to be very far away. So this gives us a little bit of an idea of what we can think about the numbers, what reopening schools might do to the transmission. So next slide, please. A different way to think about the problem is if we think of schools as a kind of network. So for the Netherlands, we have a registration for all pupils. We know exactly to which school a pupil is going and to which school its household members are going, the other kids in the same household. And it's a very accurate registration because this is the way schools get the subsidies. And we say that any 2 schools are connected if children from the same household visit these 2 schools. So most likely it's a younger sibling visit primary school and older sibling goes to secondary school. Then these 2 schools are connected. And then we can do that for all the schools in the Netherlands. And we can set up a next network. And we see that then the secondary schools are the kind of hubs in this network. And that simply reflects something we know for the Netherlands, and I think it's also true in a lot of other countries, but I guess not in all, is that the secondary schools have a much larger catchment area. Children have to travel way farther, the schools are much bigger. And the schools for the primary schools tend to be much more local. And what this means, if we then do some simulations, this is the graphs you can see on the right-hand side. If an epidemic would spread after reopening the schools, we can see that at most about 99%, so practically all of the open schools could be infected. So all the schools are connected to each other. And if we only reopen the primary schools and daycare centers and an epidemic would spread, we can see that at most infection can reach about half of all the open schools. So we see that then the network gets fragmented. The schools are very local. They can only transmit infection to other local schools. And this is a very important consideration for, like, if you want to be careful to first open the primary schools and keep the secondary schools closed, so that you limit the size of an epidemic if it would start. And this is work that we did together with the London School. And next slide, please. We can also do what I would call a more conventional modeling approach, where we use a compartmental model that basically partitions the population into people who are susceptible to infection, those who are infected, and those who have recovered from infection. We can structure it by age, and we use the age-specific probabilities of being admitted to a hospital or an ICU, and we fit that to the Dutch data. Then we can do simulations, and that's shown in the next slide. This is the consequences for opening daycare centers and primary schools in the Netherlands for the number of occupied beds in the ICU. So that's the number of occupied beds is the number you see on the vertical axis. The day in the year is on the horizontal axis. And we've drawn different lines for different scenarios. Like there's a scenario if we would not have taken any measures, that's the red line. So you see that high up in the right hand corner. Then there's the situation, what would happen if we continue school closure and all the other measures. That's the green line, and you can't see it because it's completely overlapped by the blue line. That's what would happen by reopening the schools on the 3rd of May. So the main conclusion here is that using this particular model, we see hardly any difference between closing and opening the primary schools. And of course, this is just a model, and as I keep on telling, all models are wrong, so you shouldn't believe it, but it just shows that if we change the things in this model, we see hardly any effect. And the point I wanted to make is just that we've been doing some calculations to show that the maximum effect, what we expect, is a decrease of 0.2 more secondary infections per primary case, the worst case that we can imagine. And this is showing a kind of a realistic, what we think is a realistic or even a best case, is that we would see hardly any difference in the number of hospital admissions. And that's of course also because children don't go to the hospital if they are infected, but it also shows that they don't transmit much infection to the teachers and the parents who might be taken into the hospital. So next slide, please. So the conclusions from our efforts in just a few sentences are that I think it's important to use different modeling approaches to get a little bit of a feel for what school closure and school reopening might do. And it also is necessary to use different modeling approaches to account for the uncertain role of children in transmission, like we've heard in the previous presentation, the current state of knowledge. And basically, we don't know things for sure, so you have to account for that. And we also have to account for the different roles that different schools, say, for example, primary and secondary schools have in transmission, and account for that. And that's what we use to explore the range of the expected impacts. And we don't use our models to make definite prediction, just to get a bit of a feel. And we use it to inform how we set up our monitoring system, which I think is the most important part, like a monitoring system to see how transmission might be affected by schools, how many teachers might be infected, and how many teachers might be infected. And basically, that's my presentation. Like, thank you so much for your attention, and thank you for this opportunity to present this work.
Thank you to you, actually, for coming here and presenting the work. It's the findings, I think, of your modeling are consistent with the thinking in Switzerland, as they have, which is where I'm based, obviously, at the moment, and they've opened creches and young childcare facilities from this week with a phased approach going up the age groups of returning to school. So yeah, interesting that it's happening. Vittoria, thank you so much for joining us, and welcome to the call. Over to you.
Thank you very much to you, and thanks everybody for this invitation. So I have my slides. I can probably share the screen. Let me try. Okay, it's much longer than. So you have my slides also. Would you like to probably show
Let me.
Otherwise, let me try one thing. I sent them by email.
Great, I've got them now.
Because I have too many files open, and so my Zoom, when they ask me to share the screen, ask me what, and okay. Probably this one. Let me try if it is the good one.
Otherwise, I can.
No, yeah. If you put them up, it's probably better. Thank you. Sorry.
No problem. This is the one?
Yes, perfect.
Let me try and open it.
So I wanted to present a little bit the work that we're still currently doing. So this is still ongoing and we haven't finished, but it goes very much along the lines of what Jaco was mentioning. We specifically looked at the region of Île-de-France, which is the region of Paris and is the most affected region. And we had done a previous study in which we looked at different exit strategy, starting from beginning of May or beginning of June, where we always considered schools to be closed. Then the French government announced that schools for the younger school levels were going to be open starting May 11. And so we quickly went back to the model in order to understand how to, let's say, understand the impact, assess the impact of the school reopening. Next slide, please. Of course, this is extremely dependent on what assumptions we put in the model, and the evidence so far, as Rosamund was saying before, is highly contrasting. Now, the things that we learned is that, of course, children are most likely to be asymptomatic or have very few symptoms. We still don't know much about possible outbreaks in schools, also because of contingent events. In some cases in Southeast Asian countries that were first hit by the pandemic, some of them were experiencing school holidays, so the schools were not in session. Then during the early phase, for example, in Europe, contact tracing was done only, and testing was done only on contacts showing symptoms. So a lot of cases in children may have gone undetecting. And there is one example that shows that it is a cluster in a high school in was a department in northern France, which was hit. It was the first big cluster that France had, and that led to a large contact tracing investigation. And during the contact tracing investigation, only 2 symptomatic cases in the high school that was linked to this cluster were found. However, testing was not performed on the other students because the testing was performed only in presence of symptoms. Now, a follow-up serological investigation that was performed later reported instead that there was a large circulation that occurred at a high school, and infection attack rates in the adolescents, so in the students, because this is a high school, were quite similar compared to what measured for school staff and also for teachers, and larger than what was measured in terms of infection attack rates for the household members. Also, that was February, and during that time there were 2 weeks winter holidays in that region, and reconstructing the epidemic curve from the symptomatic cases, it is possible to see also that there was a substantial drop of symptomatic cases after the in correspondence of the 2-week school holiday in February. So what seems to suggest these studies that probably the role of adolescents is more similar to what we know of for asymptomatic adults. So the transmission, there was a large transmission within the high school, but this doesn't tell us anything about instead what happens in younger age children. If we look at large scale testing studies that were performed in Iceland and in the city of Vo in Italy, which was the epicenter of the initial outbreak in Italy, the study showed that at the population level, children under 10 years of age had a lower incidence than adolescents and adults. So this seems to indicate that probably there is a differentiating role of children in their epidemic, depending on age. Recently, there were several studies also showing, and one that came out yesterday or a few days ago, showing, for example, that the viral load is the same across different age brackets. And the authors suggested that this may be an indicator of the risk of reopening schools. However, viral load doesn't necessarily translate easily to transmissibility. We know, for example, from other studies that viral load is the same between asymptomatic and symptomatic infectious individuals, even though a large contact tracing study in China showed that transmissibility increases with the presence of symptoms and also with the degree of severity of the symptoms. So overall, if we synthesize all of this information, there are still two hypotheses that are probably still valid, and what concerns a different susceptibility of children, and another one instead different infectivity of children. Now, a modeling work by the London School some weeks ago showed that according to the data that were available at that time, the assumption, the hypothesis that was best fitting the data was equal susceptibility, and then instead a different infectivity between children and adults, and also a different degree of symptoms. So we started from this hypothesis. Next slide, please. And we built a transmission model that is age structured. So very much what Jaco was presenting at the end as a conventional model. These are standard approaches that are based in structuring the population according, in this case, to the age. We looked at 4 different age brackets. In previous works, when we were looking at exit strategy, we just looked at children altogether up to 18 years old. But now, given the last results, we decided to, and also given that schools may be opening depending on the level of the school, of the education system, then we were forced, of course, to split the children age classes into younger children up to 10 years old, and then adolescents. Now, excuse me for the informal notation on the slides. This is still work in progress. So this is how we call them between ourselves, between collaborators, when we exchange some of these results. So the hypothesis, we're looking at a compartmental model that includes incubation period, transmission before the onset of symptoms, in case symptoms are developed, includes also asymptomatic, and then includes for the severe different degrees of symptoms, and for the severe cases, the hospitalization and also admission to ICU. So based on what I was presenting before, we assume that susceptibility is the same across different age classes, but for children, both young age and teenagers, we just assume that they are asymptomatic or they have very few symptoms. We consider the reduced transmissibility because of asymptomatic and few symptoms, and this was obtained, an estimate obtained from a model, was inferred from a model that was calibrated on the outbreak in China. And then we consider that teenagers behave as asymptomatic adults in terms of their transmissibility, and we assume a possible variation of the transmissibility in younger age children. And we span it across different values up to the same transmissibility that is assumed for adolescents. Next slide, please. The model is calibrated on admission in ICU in the region. And here you have the data points, and just this to give you an idea of how the epidemic evolved so far in the region of Paris. France has imposed a national lockdown on March 17. And here, of course, on the curve on the admission, you see a bending and then a slowdown of the number of new admissions per day a few days after because of the progression of the disease. So the continuation of the growth after the lockdown that is indicated by the vertical line is due to the fact that those were infections generated before the lockdown was put in place. Based on these curves, we estimated a reproductive number that is around 3 before lockdown was implemented, and is currently around 0.5. We continue, of course, recalibrating the model as soon as data comes and becomes available, consolidated data, of course, accounting for all possible delays in notification, because we keep these indicators as important indicators to understand what will be happening on May 11, that is the date decided by the French government to reopen and lift the lockdown if epidemic conditions allow. And among the epidemic conditions, of course, there is not only the number of cases in the community, but also the new admission in the hospital, in the intensive care unit, and also the occupation level of ICU of course, in the ICU system. Here I'm showing once again exclusively for Ile-de-France, and you see that, for example, the latest available data that we can trust arrived to a few days ago, about last week, and we're still, the horizontal line are the capacity that where the dotted line was the first expansion of the capacity in terms of number of ICU beds that was done by the region. The second line, the straight continuous line is the capacity that was current capacity of the region. You will see that the dots, so the data go above this line, but it is also due to the fact that there were some transfer of patients from Ile-de-France to other regions that were less affected, and that of course are not counted in the number of beds occupied because we don't have that information. So that's why it goes a little above. The situation at the moment is still of a high tension in the region in particular. Now, next slide. In terms of exit strategies, starting May 11, we looked at a variety of very different social distancing interventions, coupled also with case isolation. Here I'm showing just one example. In the study we made before, we looked at 30 possible different combinations. And as Jaakko was presenting before, what we are doing is basically is that we're acting on the number of contacts which are established in different locations, like for example, school, work, the number of contacts established by a given set of individuals, for example, seniors, and also the number of contacts which are established on transport, or for example, other leisure activities or other type of activities. Now, as an example, what I'm showing here is a set of intervention, social distancing intervention that we called moderate, coupled with case isolation. And these include, originally, schools were assumed to be closed, and now we are testing the reopening with different protocols. And then we assumed for this moderate intervention that a portion of individuals will be able to go back to work. Currently, there are estimates of about 70% of individuals not going to work, so staying at home either because they do telework or because their activities have closed. Imagine, for example, restaurants and cafe staff, or because they are caring for their children. So very different options including in that. Then we are also considering that seniors remain protected in that they would continue reducing their number of contacts with the rest of the population by a certain amount. And then in this particular side of intervention, we assume that some activities which are non-essential activities currently closed during the phase of lockdown would partially reopen. These interventions are also coupled with intensive case tracing, testing, and isolation. Now, if we go more specifically on school reopening, of course, as we heard before, there are several different options, and countries are aligning on different protocols and planning. The French government announced a return to school for preschool and primary schools on a voluntary basis starting on May 11 and in a progressive fashion. Now, how this progressive is going to be put in practice is still unknown. What we know is that they put a threshold on the largest number of students that can be in a classroom. That was what Rosamund was saying before, a maximum of 15 students. And of course, this is creating a lot of logistical problems for schools to be prepared in terms of hygienic measures, in terms of social distancing, and in terms of logistical organization of how to handle a lower, of course, rate, a lower density of students at every single moment. So we proposed to look at 4 different scenarios. The first scenario is that is progressive and that allows progressive up to full attendance. So we assume that during the first week, only 1/4 of students would go to school, then half of them on the second week, 3/4 on the third week, up to all students going to school starting 1st of June. Now, this clearly, in order to be put in place, given the restriction of the maximum number of students per class, can be envisioned either if space is available. This is very context dependent. You can easily imagine that in a highly crowded city like Paris, this is impossible. There is not even open space to do that. But we can also imagine that if schools at higher levels, for example, middle schools and high schools remain closed, it would be possible to use those structures, for example. A second scenario that is progressive up to 50% attendance only. This would be consistent with would be able, let's say, to ensure a 15 students per class attendance only. And of course, there are several different ways of doing that, either having students rotating between 1 week and the other, so half of them going 1 week and half of them going another, or half week, similarly to what Austria, I think, is doing currently. Or there were also suggestions of having 2 different turns, first one in the morning for half of the students and a second one in the afternoon. Now, clearly, it seems currently in the situation in France that this is left to the organization of schools and also to local administrations. Then, in order to test something that is instead very different, we looked at something that is not progressive. So we assume in one case that 50% of students would go directly, immediately to school on May 11. And of course, a worst case scenario in which everybody in the preschool and primary schools only would go on May 11. Next slide, please. Then there is a second set of scenarios. So once again, this is based on current recommendations that, of course, may also evolve depending on the situation that we're going to experience in the next weeks. This scenario assumes that there is a reopening also of the higher level classes, middle and high schools, and this could start a few weeks later. Now, currently, the government is stating that starting already from May 18 middle school could go back to school, but only in those departments that have been weakly affected by the epidemic. And Ile-de-France is definitely not the case. So we thought about a possibly later reintroduction of the students into the school, into the educational system. And once again, we looked at introducing adolescents to school in a progressive way, with the different, or in a sudden way, starting June 8th, and with a progressive, and with a full attendance or limiting the maximum attendance. These starting May 11, of course, there are some considerations also to be taken into account in the difference between choice of different countries. France still has 8 weeks of in the school calendar. Other countries, for example, end their school calendar before, at the beginning of June. And so, of course, all of these considerations are taken into account also on this planning. And then a third set of scenarios, which is, next slide, please, Sarah. Thank you. Which is instead a worst case situation in which we're using as a sort of a benchmark, in which we allow all schools to reopen from May 11, and through a progressive or sudden protocols up to 50% attendance or up to 100% attendance. Now, let's say I'm not able to show you fully the results, but I wanted to show you the next slide, which is going to be my last. The next slide, please. Thank you, Sarah. In order to show you what kind of results one could have. This is very much in line with the results that Jaco was pointing out at the end of his presentation. On the left, you have only opening for preschools and primary schools from May 11, and there is not so much difference in between the different scenarios, whether there is the reopening is progressive or not, whether the attendance is full or not. Here I'm showing the number of new clinical cases. Clearly, new infections generated in the younger age classes are not counted here because they would be asymptomatic, and so we wouldn't see them among the clinical cases. But there will, and there is not so much an increase. The number of clinical cases remains pretty flat throughout the next 2 months after reopening of the schools, if only preschools and primary schools are opened. Now the situation becomes different if we also have the reopening for adolescents, so for middle school and high schools. And if they start, if these are reopened on June 8th, which would be the central plot, you will see that there is an increase which is stronger if the reopening is full, so all adolescents going to school on June 8th without being progressive over time. If it is progressive, then once again, the number of contacts would not be so high to produce a large number of new cases in the rest of the community that is visible on the time frame that we are looking at. Now, it is important, on the other hand, to remember that these are the clinical cases, and we're looking at those in these 2 months, May and June, because that is the reference frame that we're looking at. But then the increase you see in the middle plot, if middle and high school students go back to school on June 8th, that increase would translate also in an increase of ICU demands in the month of July. So of course, with a delay due to the fact, due to the progression of the disease and the time that is needed from infection to eventually show critical symptoms that require hospitalization and intensive care unit. So this is already, let's say, an indicator that even if on the last weeks of school opening there is an increase in the incidence of cases, this will have an impact then the month after on ICU demand. And of course, the scenarios on the right are catastrophic scenarios compared to the more realistic scenarios on the left, and these are used as a comparative example to show that if we have, for example, full reopening without being progressive of all classes starting May 11, this would lead to a wave that is even larger than what we currently experience. Nonetheless, if the opening stays progressive, this still would provide a chance to keep the epidemic under control. Now we are of course, this is dependent on what infectivity, so transmissibility we assumed for the younger children, and we are exploring this direction. According to the results we have so far, the first set of scenarios, the one on the left that assume the opening only of preschools and primary schools, would be able to limit the transmission in the community, even with the different values of infectivity of children, so even in the worst case scenarios so far. And this is all. Thank you very much.
Thank you so much for sharing with us. We've had a lot, I think, a lot of rich information shared today on the call, and I received a number of questions over email prior to the call, as well as a number of questions that have come up during the call through the Q&A. I'm also aware that we're a little bit over time, and people are extremely busy at the moment, so perhaps we may only have time to answer one or two questions, but what I would suggest is we are in the process of planning a follow-up webinar anyway next week on the subject of schools, and we can consolidate the questions that we received prior to the webinar and those that have come through today, and try and answer these on the call next week as well. Interestingly, I think while we have our UNICEF colleagues on the line, there was a question that came in that I thought was worth a quick discussion, and that was somebody suggested, should we be making recommendations for developing trauma-informed schools as a resilience approach post-pandemic? So I wondered if you had comments on that. So I think it's along the lines of what you were saying, Robert, with regards to opening schools, but opening stronger schools.
That's exactly right. Thanks, Sarah. And that would be one of the main takeaways from the framework, is to seize this opportunity, if you'd like to call it that. I mean, it's an incredibly challenging environment, et cetera. So but it is potentially an opportunity for us now to relook at schools in the reopening process. And like I was mentioning when presenting the framework, the starting point should be, what are the needs and vulnerabilities that children will be expected to be, based on evidence of the past, based on analysis of each context, as they walk back into school. And we recognize there's an opportunity now to relook at how to accelerate their learning, bridge them as they bridge back into school, new pedagogical approaches, new innovative approaches, but also the full range of well-being, their mental health, their social emotional health, their physical health, including water and sanitation, nutrition, school feeding, etc. And to be successful from being an education person, be successful from a learning outcome point of view, indeed will need to take a holistic approach. And so I think the comment is very well taken, and we are encouraging, as this framework is being rolled out, we are encouraging decision makers to indeed look very broadly in the planning and the execution of the reopening process to meet the full range of needs of children.
Thank you. We've also had a couple of questions for our modelers, asking if the methodology for your studies will be made publicly available at some point.
Yes, absolutely. There were, I'm still on, sorry. They're always made publicly available and very well described. So some of the work that we're doing is somehow behind the scenes, but we also try, and even in that case anyway, technical reports always provide all information. And when these results are made publicly available, they always come with a full appendix with lengthy details of all the assumptions that we made. So certainly.
Thank you. And maybe a question for Rosamond. There have been a number of comments that have come through about the protection of teachers. So while children are not at risk of very severe disease, or less at risk of severe disease, what about protection of teachers?
Thank you, Sarah. I think that's a really important point. And I mean, we've all had to learn our new behaviors between washing our hands or cleaning them frequently and staying a meter or two away from the next person in line. And I think this is going to be an important consideration. I want to follow on your previous question with Robert, that there's going to be a lot of demand placed on teachers going forward. You know, there's half the kids in the classroom, half the kids on teleschooling, the logistics, as was mentioned, the organization of the classrooms. But I do think it's really important to recall that, and I think about this every day, this is an experience that literally every person on the planet is sharing right now, being part of this pandemic. But it's also an experience where each one of us has a very different experience. So while some of us are sheltering at home sometimes, going to work other times, some are required to work in very stressful circumstances, such as health workers in hospitals. But even those who are having, you know, a relatively easy time of it may have lost a relative, may have lost a friend. So that as everyone goes back to their, what used to be their old normal, to a new normal, keeping in mind the psychosocial elements of post-traumatic stress from the confinement, staying at home measures, or simply the personal experience that each person has gone through is important. So back at the school, it's not only about physical protection, if you will, including whether the country requires masks or different things like that, but also about acceptance that everybody's had a different experience in the mental health aspects of that.
Thanks, Rosamond. I'm gonna, I think, end it now because I think we've gone a little bit over time, but please, if you have submitted questions, they won't be lost. We will collect them at the end and use them to inform the planning of our next webinar. I'd just like to say thank you so much to our panelists for taking time out of very, very pressured schedules at the moment, for sharing with us and for being a part of this global discussion. And I just stay safe, please, to everybody, and thank you for being with us today. So thank you, Robert, Lisa, Victoria, Jacko, Rosamond, Jerome. Thank you so much.
Thank you. Bye-bye. Stay safe.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.